pregnancy. It is just an information that you can pass to the parents. That's all it is. It is not an indication. Because and why do we screen for it is because Down syndrome statistics these days, because the life expectancy is improved. It was 25 in 1983. Now that is that it has increased to 60 years. And 79% of the parents states that, I have already told, the life is more positive since the arrival of this child. And 99% of the people with Down syndrome, if you have an adult, or if you have seen, or if you once in a while, or in I don't know, I don't know how many of you have seen, or like you have an interaction with a Down syndrome child or an adult. They are very, very happy in their life, and they will not complain about things. They can be trained. There are so many good aspects also for this. So how to prevent a Down syndrome in a pregnant lady, or in the community, or in the society? So there are two methods, as you all know, because we all have studied community medicine. There are two methods, that is primary prevention and the secondary prevention. Primary prevention is avoid late pregnancy. See, we all know that as the age advances of the mother, maternal age is the one which is determining the non-distinction. So basically, avoid late pregnancies. And in case if you are pregnant, if you are pregnant with at around or 40s, or in your late 40s or something, there are options for pre-implantation diagnosis. That is, like, you can take your egg and the sperm, and you have to go to an IVF center. They will make an embryo, and they will test the embryo before implanting into you, so that the embryo will be tested prior, not that after they have implanted into your uterus. Once ovum pickup is done, and then after in vitro fertilization, after the embryo is formed, they will test the embryo directly, and once they diagnose that it is a euploid without any aneuploidy or anything, they will implant. That is pre-implantation diagnosis. That is a primary prevention method. These are the two methods that you can do. And then as secondary prevention, which is by informed choice. That is, once you are having a risk, or like if you are into a category where there is a suspicion of Down syndrome, there are options. That is, you can screen, which is by screening is by so many methods are there, like biochemical markers, and following that you can do direct invasive test, that is a CVS and amnio, and they will give you an informed choice whether you want to continue, or you can terminate the pregnancy. That is depending upon the parental choice. It is never ever, nobody will force you basically to terminate if you are having a trisomy 21. So these are the strategies for prevention, that is primary and secondary prevention. So we will basically concentrate on the secondary prevention, that is the informed choice method, where you have the screening methods, and also you have the power to decide whether to continue or to discontinue. So this is the first topic, like why are we doing the screening. Second is whom to offer. Whom do you offer this screening methods? Everybody will have this in mind. Is it okay to screen only the elderly women? So why do, like, only after your late 30s, or after 35 years, is it okay that we screen only these ladies? But it's not like that. The Down syndrome actually increases with the maternal age. As the age advances, the risk for Down syndrome increases. So you can see the chart here. 1 in every 1,250 babies at the age of 25. That is the incidence of Down syndrome at age of 25 is 1 in 1,250. But as you see, as the age advances, by around 45 years of age, it is 1 in every 30 babies. So age is a determining factor for incidence of Down syndrome. So as the age of the mother increases, the chances of Down syndrome is increases. That doesn't mean when you are younger age, you are not going to have a Down syndrome. You can have, but as the age advances, it is a major risk factor. So this is one of the study which was done long back. It is around 1996, but this is a very good paper. That's why I stated this. See, as the age advances, it is the strongest epidemiological, that is 0.6 to 41 per thousand is between the ages 15 to 45. So you can see that As the age advances, the incidence is increasing. So this is a study which is done in this one in England, where they reported 5,737 cases between 1918. That's long back, basically, 89 to 93. And in that also, 67% occurred in women less than 35 years. I hope you got the point. So it is never the only, like, as the age advances, you will see more cases even when the baby, even when the mother is less than 35 years. And there are three types of Down syndrome. See, there are three types. Basically, the majority will be because of the non-distinction. So how, I hope everybody knows the non-distinction syndromes. Basically, when the meiosis division occurs, half of the fathers and half of the mothers will come together and will form the chromosomes for the baby. So if the non-distinction occurs at trisomy at 21st chromosome for the mother, two chromosomes from that side will come and it will become the trisomy 21. That is a non-distinction. That is the commonest form of Down syndrome that you will see. But there are other forms also. 4 to 5% will be because of the translocation Down syndrome, where there are balanced translocations will be there for the mother. So once there are so many chromosomes which are prone for translocation, acrocentric chromosomes. So in you, if the mother is having a translocation, that baby have a higher risk for developing Down syndrome. And then the rest 1% is because of the mosaic Down syndrome, where only the gonads will have the mosaicism. So these types of cells won't be there in the blood cells. That is why it is called the mosaic Down syndrome. That is after the embryo has become, and post embryo the baby will have some mutation. Not before forming the baby, after embryo formation. Post embryo formation, there can be some mutation and it will result in the mosaicism, and that will lead to Down syndrome. So there are three types of Down syndrome. That also has to be, everybody should know that. So all this constitute, like, we are in a doubt how to start our screening and whom to offer. All these things were like, it was a big discussion in around 1996 and in 2000, early 2000s. So ISPD in 2015 stated that it is universal. That is, they have suggested a position statement. That's what they will call as position statement. They will update this position statement every 5 years. So in 2015, they stated that it is universal testing. Each and every pregnant mother has to be tested whether the mother is having a risk for Down syndrome. It is not like only the high risk group has to be tested and the other groups can be on to the third W, that is, what is the basis? How do you see, like, what is the basis for screening? So I'll now come to an ideal scenario where, like, ideal scenario is like we will have to exclude this aneuploidy 100% from everyone. For that, we can use the definitive diagnosis, that is the karyotyping. That is the invasive procedure where we used to put a needle into the maternal abdomen, and like how you draw blood from the blood vessels, we will withdraw the amniotic fluid and send for the study. This is the method where you can definitely conclude that mother or this baby is euploid. So what is the risk is like? You are having a risk of miscarriage, because you know it's a balloon which is filled with fluid, and inside that is a baby is. And so when you put a needle, you are actually making a hole in the amniotic cavity, and there is a risk for leaking or a miscarriage. It is common sense. Like, you can think, when you put a needle into the balloon, there you are creating a hole, and that can lead to miscarriage. And one more thing is like, amniocentesis is not cheap because it is expensive because of the expertise, and also this tests are being sent to centers like Bangalore and Bombay. We are not doing it like in Kerala as such. We don't have a genetic lab here. All these things contribute to the expensive nature of this test. So in an ideal scenario, you have to do invasive testing, that is the amniocentesis for karyotype, and 100% you will be sure that this baby is euploid. But we need a practical approach. Like, we can't go and prick each and every mother and confirm the chromosomal normalcy. So how do we go for a practical approach? This is what we call the personalized risk for aneuploidy. So what we do is like we will suggest the invasive diagnostic testing to high risk mothers only. So how do you find out who is a high risk mother? So there has to be some criteria to decide who is high risk and who is low risk. So there comes the role of prenatal screening. Okay. So how does you screen like mother? How does screening work? So now I'll go to the concept of screening. I hope this is clear. Somebody please respond. Like, am I confusing you?
Yes, miss. Clear.
Clear, right? I
Yeah,
thought, yeah.
perfect, ma'am.
Okay, okay. So these are the concept of screening. So we will have some filters. You have seen the what we call is like sieve or aripa. So exactly the same thing we are doing here. So this is the general population, and we will put one sieve or a filter or a filter, and then you will get some. So you will filter some of the, see, all the greens are normals and all the reds are abnormals. So first you will keep a sieve so that you will get the more number of abnormals in the second stage. I hope you can understand that. So there comes more of the red ones. Then again we are putting another sieve and you will get majority of the red ones, which we are calling as abnormal ones. So this is the concept of screening. So now we'll see what are the different filters that we use. First one is the important one, which is the maternal age, which I was talking all this time. Then comes the next one, that is the maternal serum biochemical markers. So there are certain hormones that are there in the mother when a lady is pregnant. So we use these maternal serum biochemical markers to help us. And the third one is the fetal ultrasound markers, which we, like you have seen that mothers are being sent for level 2 or genetic sonogram, where they see all these markers and will again classify them as low risk or high risk. So these are the different filters we will use so as to get more and precise risk of the mother, which we call as the personalized risk or individualized risk for that mother. So there are certain terms you have to just know about it. I'm not going so deep into this and make this a boring session, but I'll just make you understand what are these. There are words like markers. You will see some in a scan report. You can see as markers and a priori risk. Moms, you have seen in your community medicine, moms likelihood ratio, positive predictive value, then false positive rate and cutoff, relative efficacy of markers, all these things. Okay, so I'll come to each and every one separately. So what is a marker? So when you do a scan or when you see an ultrasound of an antenatal mother, 5th month scan, this is called as a level 2 anomaly scan or a genetic sonogram. You will see it will be written. If it is a genetic sonogram, in the impression you will see no obvious structural anomalies bar soft markers of aneuploidies. There are so many soft markers. So in that you will see this word marker. So what is a marker? It is anything that is found more frequently in fetuses suspected with a particular condition than in normal fetuses and therefore helps easy pickup for us. For example, in trisomy 21, there can be unossified nasal bone. See, all babies with unossified nasal bone are not trisomy 21. See, if you see 100 babies, 100 normal babies, normal euploid babies, and 100 abnormal trisomy 21 babies, I'm just telling a number. It's not the perfect ratio. For trisomy 21, you will see around 60 of them will have unossified nasal bone. Whereas in normal euploid fetus, you will see in around 20 only. So euploid fetuses also have unossified nasal bone, which is a marker. But majority or 60 of them in trisomy 21 have unossified nasal bone. So I hope you got the concept. It is found more frequently in fetuses suspected with a particular condition. So that is a marker. Now coming to a priori risk. See, a priori risk is what we call as a background risk of a mother or a person. See, every woman has some risk that her fetus may be affected by a chromosomal defect. Each of us have a risk that our baby, when we are going to get pregnant, like all of us have a risk. That is what we call as the a priori risk. That a priori risk, so every woman has risk that her fetus. This is called a priori risk. That is, it is dependent on so many things. Like if you are from your demography, your maternal age will be there. All these things will be a factor. So this is what we call as a priori probability. That is, incidence of trisomy 21, as I have already told, increases with the maternal age, and also it falls with advancing gestational age. That is, if you're suspecting a trisomy 21 at around 12 weeks, you have an anossified nasal bone, and you suspect trisomy 21 in that baby. So in the anomaly scan, you are having no other finding, just the anossified nasal bone, and this pregnancy is continuing to the maybe into the late third trimester. You are not having any other finding, means that there are less chances for trisomy 21 in this patient. That is, as the age advances, you are having an increased risk, and with the advancing gestational age, the risk of trisomy 21 reduces. This is because majority of the trisomy 21 have like they will spontaneously abort by themselves. So if there is a spontaneous abortion in the first trimester or even in the early second trimester, you can be assured that we have studied earlier in our like maybe in our 12th or anything. Maybe like because of the early trimester abortions or miscarriages, that is because of the child's on aneuploidy difficulties or problems. So this a priori probability depends on certain factors like maternal age, gestational age, as I have already explained, and maternal demography. Now, this is a chart just to make you understand that this is the risk of trisomy 21 in relation to maternal age and gestation. See, on the left hand side, you can see the maternal age from 20 to 44. See, 20 to 44. So here, from here, this is the y-axis shows the gestational age, that is from 10 weeks to 35 weeks. This is still birth. So at the age of 20, see, you don't have much risk. But at the age of 44, even at 10 weeks, you have a risk of 16. And by birth, it is increasing. That is, the probability of baby having the Down syndrome will be less, because here you can see the numbers are increasing. See, estimated risk here it is 16. So at around 44 age, at 10 weeks, you are having a number as 16. But as the gestational age advances, your risk is decreasing that this baby is having Down syndrome. Now, coming to the demographic pre-test data, there are certain things, certain factors that will modify your risks. If you are very obese, that the maternal weight, if the maternal weight is more, serum marker values are lower in heavier women. So these all can interfere in your risk calculation. That's why I'm just informing you. You don't have to take this into your heart. Just go through this and understand. If you are an Afro-Caribbean race, that is racial discrimination will be there. So if you are from this one, your AFP will be more and HCG will be more and PAPA will be more, maybe around 60%. In IVF pregnancies also, dating, HCG injection, and all these things will influence the serum markers. And basically in IVF pregnancies, you don't have to take the age of the mother who is pregnant, but the donor who has given the egg. That has to be the age that you have to take into consideration. And type 1 diabetes, all these hormones will reduce. And if you have a previous Down syndrome, then your a priori probability will fall into high risk, that you will fall into 1 by 100, which is a high risk probability. And smoking also decreases, like there is a variation in the hormones. This is just to inform you, okay? Nobody has to by heart all these things. Now coming to next factor, which is the moms, that is a multiple of median. This we have studied in our smaller classes. When you have numbers which is arranged in a random manner, how to get the mom. We will arrange them in the ascending order, and then we will get the median value. This is how we used to calculate in our smaller classes. Similarly, these are all the formulas that we have studied in our smaller classes. Similarly, moms in this like aneuploidy screening, it is like if you have a patient's value. See, moms are used when you're using maternal serum markers. So serum markers means the mother will be having beta HCG value and also the PAPA value, which you will incorporate into your screening methods. So these hormones will have a definite value. When you take blood from the mother, they will report in some values like microgram per deciliter, or that will be the value. You cannot remember that value. Only if you convert it into moms, it is easier for us to remember and you can interpret the result. If you have a first trimester screening report, they will have the biochemical markers in that, and they will write there beta HCG, serum free beta HCG will be 2600 and something value will be there. PAPA will be of this value, and you have to just see the next level. Even immediately below that, you will see the mom values. Those will be converted to the mom values. How do you convert these values to the mom value is what I'm explaining. That is, you have to write the median result, see patient's result by median result. Then you will get the mom value. And I'll explain to you what is the importance of such mom values like once we go. Now the next marker or the next dictionary, like word in the dictionary, is the likelihood ratio. See, likelihood ratio of a given marker. I have already explained you. There will be some markers like unossified nasal bone. What is the likelihood ratio of that marker? Likelihood ratio of that marker means the chances of the babies getting affected by Down syndrome if you are having such a marker. So if you have a particular marker, likelihood of ratio of that marker is calculated by incidence of the marker in trisomy 21 pregnancies by incidence in chromosomal. So these are all formulas. You don't have to know all this. Basically, you will have to know this one. This is the one which is important for you. All the markers are having some likelihood ratio. It can be positive or it can be negative. So if a marker is having a positive likelihood ratio, that will explain to you the number of times the value of the marker increases the likelihood ratio of Down syndrome for that baby. And if a marker is having negative likelihood ratio, it will explain to you the number of times the value of that marker decreases the likelihood ratio of the Down syndrome. So that is the importance of likelihood ratio of a marker. These are formulas just for completion sake. These are all not needed for you. I'll tell you. Now coming to the screening designs. See, initially I have explained whenever a mother is there, you will have an a priori probability which is based on the age, and then you will have your demography. All these things will be there when you are having an a priori probability. Then you will use blood for screening. As I have already explained, they will take the hormones and will give you an absolute value. So these values will be converted to moms. Then moms, after that you will go to the scan also, which have the likelihood ratios of some of the markers. And all this, that is a priori probability into likelihood ratio of that marker, will give you the post-test probability. This is how the screening design works. It's not very simple that you do a scan or you see a test result, you can interpret. All these things has to be there inside or in your mind before commenting to the patient. So if you have multiple markers, so a priori risk means the basic risk of a mother because of the age, gestational age, and also the demography, into composite likelihood ratio. If you are having a multiple markers, like some of them will be having positive likelihood ratio, some of them will be having negative likelihood ratio. All these things has to be combined and multiplied with the a priori risk, and which will give you the patient specific risk for a Down syndrome. And now you come to the point where you have a cutoff, which is an arbitrary value for defining a high probability group. Now you have reached a risk value. Now you understood how to get the risk of a particular pregnant lady in that pregnancy. Now, when you get a value, you should know whether it is high risk, low risk, or like how to go about in future, like how to continue, how to counsel your patient, how to inform this is to be like you have to be worried, or you have to be assured, like you can assure the patient that your baby is normal, you don't have to worry about anything, or you have to tell you have to go for other tests. All these things has to be informed to the patient. For that, we are creating an arbitrary value. See, this is the chart. It is calculated by. Uh, it is actually if somebody like if people who knows this statistics properly, like Mahalanobis distance is there, where you will take number of fetuses with the maybe at around first trimester. First trimester, 100 fetuses you will take, and you will mark all the features of these fetuses, and then you will get a distance, which is a statistical measure to identify the potential causes of syndromes by analyzing multiple fetal measurements. So in this, see, if you're taking, this is the population in which you are where you are these are this is a zero, like, or the center, and this side you are having patients without disease, babies, and this side with the disease, and these are the test result. So this is the test results in the down. So if you're having a value which is more than 250, see, you are having more of fetuses without disease. And if you are having, if your final value, which I have told, like potential, you got a value which is less than 250, you are having fetuses with disease, like you will cover babies with disease more. Initially, not even initially, in UK and all, high risk is considered as 100, so that you will get only true positive cases. Here you cannot do that, because in our country, if you are telling only 100, like if you are taking as criteria as 100, none of them will do screening, none of them will do all this ultrasound test, nothing will be done. They will simply go about this test and will finish off there. So we are taking our criteria or our arbitrary value. In India, it is 250. 1 in 250 is our cutoff value, so that we can tell it is high risk or low risk. In India, it is 250. If your final risk value is above 250, that is more than 250, you can tell you are in the low risk category. If it is below 250, you will be there with the disease, like you are having a more chance for disease, so that we are like getting there are, it is a parabolic curve where you will get the true negatives also, I mean false positive plus true positive here. So there are more chances that you may miss some of the true positive cases here. See, here also the true positive cases are coming. So there is an overlap region. So cover this, to cover this one also, we are increasing our criteria to 250 to cover this one also. So now next topic is like when to screen. So you understood how the screening works, what is the basis of screening, what is the model, everything. Now when to screen to rule out aneuploidy. So there are so many screening models. These are the screening models like age-based screening, where I told you, like as the age advances, you are having a more risk. Then come the first trimester, where you have the NT-based screening, double test, combined test, and additional ultrasound markers. All these things will be explained, don't worry. Then in second trimester, you will have the triple test, quadruple test, and the genetic sonogram. And then comes the integrated test, which is also the sequential and contingent screening methods. These are the combined methods which will be explained. So these are the screening models which you have to go follow. So you'll be confused which test to be used. So initially I'll explain to you that these are the methods. So in first trimester, initially you a priori probability will be there, where you have a maternal age, and this will give you a 30% of your final risk. Like you can detect whether this baby is having a risk by 30% only by the maternal age and demography. So you are adding the next step, which is the blood test. You are withdrawing blood and giving the serum markers. So that will add the detection rate to 50%. So this is what we call the double test. So with the age, and the blood test. If you are taking only the blood test without the scan or anything, this is called as the double test, double marker test. So when you include the scan inside, so you are having the scan where you will see the NT, nasal bone and all those markers. So when you are including a scan and together with that, if you are taking the blood, which is called as the combined test, and it detects around 85%. So combined test has a detection power of 85% in first trimester. So this is the next step where you will use additional markers. In the first trimester, if you're sending the scan to a specified place where there is a specialized fetal medicine consultant or a person who is FMF trained, they will add extra markers, which is called as the ductus venosus flow, and also tricuspid regurgitation, which is a markers of the first trimester. When you're including all these things, your detection rate increases from 92% to 95%. So this is what we call combined test plus additional markers. So even by first trimester, you can detect whether this baby is aneuploid or euploid, like aneuploidy difficulty is there, or this baby is euploid by all these things, and you have a detection rate of around 92 to 95%. So whenever you are getting combined screening, you should understand the combined screening means ultrasound is included. Double marker test means and the scan findings are not incorporated into it. It is only the blood test and the demography features of the mother. So combined test plus additional markers is the ideal one, and that will give you 92 to 95% of the chances whether this baby is affected or not. Now I'll explain to you about the serum markers. So these are the serum markers that you will get in your first trimester screening, that is free beta HCG and PAPE. They both are placental product. So, and what is the timing for this first trimester screening? So 11 to 13 weeks, 6 days is the timing. 11 weeks to 13 weeks and 6 days, where the CRL is 45 to 84 millimeter. Everybody, please make sure that you really stick to this. Only when the CRL is 45 to 84, you can take that scan as reliable, and that too if the gestational age is between 11 to 13 weeks and 6 days. So ideally, go for 12 to 13 weeks. And the risk I have already explained to you, because cutoff is 1 in 250. So now coming to the second trimester markers, which is a triple marker test, quadruple test, and the genetic sonogram, which is the ultrasound. So now we'll go to the second trimester markers. The second trimester markers, alpha fetoprotein, conjugated estradiol, and HCG and inhibin. In this, alpha fetoprotein is secreted by fetal liver, estradiol by fetal adrenal gland, and beta HCG and inhibin by placenta. So how the screening model is like this. See, triple marker test uses alpha fetoprotein, estradiol, and HCG, and there the detection rate is only 60%. And these days, triple marker test is obsolete. You are not going to use triple marker test these days because it has a very less detection rate, 60%, which can be detected by a genetic ultrasound or a genetic sonogram. If you're doing a sonogram, genetic ultrasound, the detection rate is 60%. Then why do you have to spend extra on this triple test? Better, you can go for a quadruple screening test where you will get the 4 hormones, and detection rate is a little bit more, maybe around 65%. So whenever you are going for a second trimester screening, if you have missed your first trimester screening, first trimester scan or everything, you can go for a second trimester screening, and in that you have to choose the quadruple test and not the triple test. So in Down syndrome, the fetal products will be reduced and the placental products will be increased. This is the pattern that you will see the hormones in a Down syndrome positive baby. If your baby is having, or the fetus is having a Down syndrome, the placental products means the hormones from the placenta will be more and the fetal products will be less. So this is the mom value. See here, you can see here the beta HCG values are more. Here the beta HCG is increasing if the this Down syndrome affected baby, and the PAPE will be less. So in your first trimester screening, if you can see the pattern as beta HCG is increasing and PAPE is reduced or PAPE is decreasing. See them, everybody's will be mom value has to be 1. That is the ideal value for both the beta HCG PAPE result when you see a first trimester screening. Beta HCG has to be 1, mom value I'm talking about, and PAPE has to be 1. Any increase in the PAPE, any increase in the beta HCG, any decrease in the PAPE has to be seen properly, mom values. If you're seeing a 2.5 moms of beta HCG and 0.4 of PAPE, you can have a doubt this baby can be affected because the hormones are showing the pattern in such a way that the beta HCG is increasing and PAPE is decreasing. So this is how the pattern goes. If the beta HCG is increasing and PAPE is decreasing, it can be a pointer to the trisomy 21. It doesn't mean that the baby will be affected, because if the hormones are showing this pattern, you will go into at least a high risk or this baby can be affected. So whenever you get a high risk value and see the hormones, if you see this pattern, always ask them to do any other test so that so as to confirm the aneuploidy status of this baby. And in trisomy 13 and 18, both the hormones will be towards the lower side, maybe around 0.2 or 0.1 or something. If you're seeing all such things, it can be a pointer to trisomy 13 and 18. This is the second trimester. Again, AFP will be reduced in all these syndromes, 21, 18, and 13. All these things, trisomy, all these trisomy, AFP will be less. And beta HCG and inhibin, both of them will be more in trisomy 21. If you get a quadruple screening test and if your beta HCG and inhibin is very, very high, you can suspect a trisomy 21 without doing any scan or anything, just by seeing the hormonal values. That's what I wanted to make you understand. In trisomy 18, all the hormones will be less. All these hormones will be less. So whenever you are having all hormones less, just ask them, you have to evaluate more for trisomy 18. So now coming to the second trimester timing, it is between the 15 to 21 weeks you can do the second trimester screening, which is a quadruple screening, which is the better screening among the second trimester options. So here you have to incorporate scan also, so that the BPD has to be between 31 and 52. Sometimes I have seen scan reports where they will do quadruple screening together with the scan and the BPD will be less than 30. You cannot take that into consideration because the BPD is less than 30. And if the BPD is more than 52 also, it is not a reliable test. So make sure this has to be seen properly. It is between. So ideally, you can go behind between 16 to 18. So whenever somebody has missed your first trimester scan or screening, you can ask them for a level 2 anomaly scan, which is done from 18 weeks to 22 weeks. Maybe you can send for an early anomaly scan, which is around 16 to 18 weeks with the quadruple screening, or send an anomaly scan, like anomaly scan, which is around 18 to 19 weeks, so that you can do an anomaly scan. Together with that, you can do finish off the quadruple. Here also the risk is same. Cutoff is 1 in 250. Now coming to the genetic sonogram, I have already told you the detection rate of a triple marker test is about 60, and the detection rate of genetic sonogram is 56%, and the false positive rate is 3%. So I have already explained you there are markers, and these are the markers which we will see in an ultrasound. See, these are the likelihood ratio, positive likelihood ratio, and these are the negative likelihood ratio. Of these are explained in an isolated markers. Okay. So whenever you are doing a scan, if you are having a cardiac echogenic focus, if you have an calcium deposit in one of the leaflet of your valve, which is called as the EICF or cardiac echogenic focus, it has a positive likelihood ratio of 5.8 and a negative likelihood ratio of 0.8. I hope it is clear now. Ventriculomegaly, increased nuchal fold, ARSA, aberrant right subclavian artery, absent or hypoplastic nasal bone. All these four, like ventriculomegaly, increased nuchal fold, ARSA, these are the major markers which have the positive major likelihood ratio. You can see the ventriculomegaly, which has a high likelihood ratio of 27.5, increased nuchal fold, which has again high likelihood ratio of 23.3, and ARSA 21.5, absent hypoplastic nasal bone, which has a 23.3. So these are the things you have positive likelihood ratio. So if you do a genetic sonogram and none of the markers are present, like you don't have any markers, you have a reduction of 7.7-fold reduction for the chances of Down syndrome. So if there are no markers, you are again risk free. So that is the advantage of doing a genetic sonogram. You will see all these markers. When you are having any of these markers, your risk increases depending upon the likelihood ratios. So now, what is this integrated test, which is called a sequential test screening or contingent screening? So in integrated test, you will use both these tests. That is, again, the same demographic factors, ultrasound will be there. You will take the blood. Quadruple screening is usually seen in the, like, or we associate the quadruple test at 16 weeks. So it has a detection rate of 93%. But the disadvantages in an integrated screening, whether it is contingent or sequential, you have to come again for a second blood test. That is the disadvantage of integrated screening. I'll explain. The disadvantage is that the patient will not come again for the second blood test. So I'll show you what is contingent screening. So initially you will do a combined test. Combined test means ultrasound is also there. You do a scan also, you get value, which is a low risk. It can be divided into three, okay? High risk or low risk or intermediate, whatever. See, if you are having a low risk, no other testing is advised, nothing is advised. If it is a high risk, you have to go for a direct testing, or if it is an intermediate risk, you have to come again for the next blood test. So when you are in the low risk or in the intermediate, I'll explain what is this low risk and high risk. Don't worry about that. When you are in the low risk or intermediate risk, you have to come again for the next testing at around 16 weeks, which is a quadruple test. So this quadruple test, again, you will have to see the result. And if it is low, there is no testing. And again, if the result of quadruple test is intermediate or high, you will have to go for direct testing. So what I have already explained is like, the disadvantage is the failure to return for the second blood test. And what is sequential? This is contingent, okay? So here, first you will do a combined test, then you will come again at 16 weeks for a quadruple test, and then only you will see whether what you have to do or not. You will not come to a conclusion after doing your first test. In sequential testing, again, this is also of two stages. Initially, you will get the combined screening will be done, and then again at 16th week, you will have to do a quadruple test. Here, the initial test, initially for this combined screening, you have an a priori risk which is your maternal age and all this demography. When you're doing the quadruple screening test, your a priori risk will be taken as this first trimester screening test. Post risk of the first becomes the a priori risk of the second. And hence the detection rate is around 90%. So when you are taking the quadruple test here at 16 weeks, your prior risk will not be that of the age or anything. Your prior risk will be taken as a risk what you got after your first trimester combined screening. So that is sequential screening. So now you will be more confused. Which has to be done? Whether I should go for a first trimester combined screening, whether I should do a quadruple screening, whether I should go for a contingent or a sequential screening. I think everybody will be confused. Now I'll explain the detection rate of each test. So when you're doing only ultrasound, okay, when you're doing only ultrasound, it is 70% detection rate. Combined screening will give you, combined screening means you will have to combine this thing, what is that, blood test, which will give you 82. Combined plus scan plus this thing, you will give you 92%. When you have a triple test, it is only 60, quadruple 65. This is the detection rate. So it's always first trimester is the best trimester where you get the better results, and also you will have an earlier detection of the aneuploidy. So keep this in mind, first trimester is the best trimester because even with NT alone can detect about 70%. When you combine the double test and the scan, 80%. When you add additional markers, it is 92 to 95%, which none of the other tests can give you. So it's always the first trimester combined screening with the markers, with the soft markers of the ultrasound will give you the better detection rate, which is about 92 to 95%. So why is it? We will pick up more, pick up early. And what happens if you pick up early? early diagnostic testing, even by CVS, which is known as a chorionic villus sampling, where we will take a needle and we will get a placental biopsy. In case if you are in the high risk, you can do a placental biopsy and will find out the definitive or conclusive result whether the baby is affected or not. So pick up more and pick up early will be done only if you do a combined screening test in your first trimester screening. And you will have an optimum time for NIPT. NIPT is the latest or superior screening test where you have a 99% of the surety where you are doing cell-free DNA testing. So option of first trimester termination is also easy if you have a pickup early, and you can decide. You can give the option to the parents whether you can continue the pregnancy or like whatever it is. They can go and decide. We can discuss with their parents. They can discuss with their relatives or even with the consultants and everyone. So ideal timing for first trimester screening is first trimester screening. See, the biochemistry will give you a good value. Like all the beta HCG and PAPA values will be reasonable and reliable at around 11 weeks. But the anatomy you can see only after 14 weeks. To be frank, when you do one first trimester ultrasound, in before 14 weeks, it is very difficult to make out all the anatomy. Basically, about the heart, about the lips, all such things you cannot see. So when you're doing a first trimester screening, you have to come into a truce between the both. So we select 12 to 13 weeks. When you send a patient at around 11 weeks, the nasal bone, all such things will not be ossified. And you will have to tell that you have to repeat again the scanning at around 16 weeks and 16 weeks to see whether the nasal bone is ossified, whether it is a normal variant, or all these confusions will be there. And if you go beyond 14 weeks, you can see the anatomy well, but your hormonal sensitivity, hormones, maternal hormonal values, their sensitivity reduces. So it's always better you send the patient at around 12 to 13 weeks so that we can meet at a decent place where you will get a good biochemistry and also anatomy. So this I have already explained. So now this is how you measure NT. Now I'll come to the importance of an NT scan. Like why do you there are certain criteria to take NT scan or NT measurement. This is how you have to see NT in an NT scan. I don't know how many of you have seen such an NT here in your scans, or like whenever you have seen a scan report. This is the ideal NT measurement where you can see this is a nuchal translucency. This is a mid-sag view where you can see the three lines here. So this is the tip of the nose. This is a nasal bone and not this. This is a nasal bone and this is the palate where you see you can exclude. If you are seeing your palate like this, you can exclude the cleft palate. And this is the mentum, your chin. So when you see a image like this is an ideal NT image. I'll explain why. Because if you are not measuring NT, you will have to pay a very huge price basically. This is a paper. If somebody wants to read, you can read this paper. See, what happens is like if there is an inaccuracy in the NT as small as 0.5 millimeter, there is significant negative impacts. That is, the detection rate will be reduced. So, and also you are sending you have a patient and you are sending up this thing NT scan to a very decent place where they take NT decently and they measure everything correctly. But if they are not sending into a good lab, then also it's over. So just as it is completely accepted that laboratory measurements require standardization and quality assurance, similarly, the NT measurement also has to be done from a proper person, and it has to be sent to a very good lab which is approved by FMF. These both has to be kept in mind. Now, this is another study, okay? Basically, the relation between CRL and aneuploidy. This study concluded that at 10 to 13 weeks of gestations this is the CRL. CRL, it is in millimeters. So 45 to 84 is the millimeter CRL that we usually take in our first trimester. So from 10 to 13 weeks of gestation, The fetuses with trisomy 13 and 13, 18 and 21 are compared. And here you will see that these 13 and 18 will have a growth restriction. See now, this is a 50th centile. All the fetuses will be are seen, majority are seen below this line, which shows that there is a growth restriction. Whereas in trisomy 21, the growth is normal, which is chromosome exactly like the chromosomally normal fetuses. So the impact of crown rump lump and error is also this is another study. I'll show you. See, why is it studied that 95% limits of report, there will be intra and interpersonal variation will be there. In the CRL also. CRL and NT has to be measured by a trained person. Otherwise, your results will not be reliable. See, the study results, there even if there is a 5 millimeter error in CRL can change the combined risk by 0.5 to 2.14 times. So basically CRL and NT has to be taken by a proper person, proper certified trained person. Now where to send for screening? You got how to screen, when to screen, what are the models, everything you understood. Now once you get all these things, where do you send? You have to send to an accredited lab with the software which is accepted by FMF, which is a Fetal Medicine Foundation. And also one more thing is like you cannot send the samples. You will do an NT scan today and you cannot withdraw the blood after 72 hours or anything. You have to do within 48 hours. You have to do a scan today and within 48 hours you have to collect the blood so that the result is reliable, and it has to be sent to any FMF accredited platforms like all these things. Now coming to the screening in multiple pregnancies. So what happens in twins? Which screening method will you use in twins? So in first trimester, you can use the same thing. NT and serum markers can be used, but the thing is like performance of the serum markers will be a little bit poorer, but it is not bad. So initially you have to send twins or multiple pregnancy twins basically to a very good scanning center so that they will establish you the chorionicity. If you have a monochorionic pregnancy means the genetic status of both babies are same. So it is the identical risk for each fetuses. If you are having a dichorionic twins, it is mostly dizygotic and you will get a separate risk for each fetuses. So for monochorionic twin, you have only one risk because the genetic composition is only one, it is monochorionic. Whereas in dichorionic, you will have separate risk for each fetuses. So this is the first trimester screen that you have to do for twins. Similar, same like singleton only, you have to send to a decent place. That's the only thing you have matters. Second trimester screening does not have a role in twins because it is less accurate than that of the singleton pregnancies, and you cannot do a quadruple screening or triple marker screening which for a twins which is not reliable. So for twins, if you have missed your first trimester screening, you have to go for superior screening test, which is NIPT, not quadruple. So this is a meta-analysis which shows that accumulative evidences that a combined test is in the twins, it is good. It is seen to be best as first trimester screening only for the singleton. So the combined test provides some improvement over the NT-based screening by decreasing the false positive rate. Now you will have thought like what we do for triplets. And triplets and higher order pregnancies risk is only based on ultrasound. There is no serum markers, nothing will be there because all the placental products will be so high because you are having multiple placentas. So you cannot, and there all this will have separate programs, triplets, all these things. So whenever you give a sample, there is no screening for triplets. Whenever somebody bring a triplet screening with combined screening for a triplet, please don't accept that and please tell it is not reliable. And whenever you are having a vanishing twin means initially you will have two fetuses, and as the pregnancy advances, one of the twin won't be there. One of the twins' heartbeat will be absent, and you will see only one twin with some parts of a twin, which is called as a vanishing twin. If there is no fetal pole, you can consider it as a singleton and do the screening method as singleton. Like if fetal pole is not there, I repeat, if there is no fetal pole, you can consider it as a singleton and continue as first trimester screening. If there is a fetal pole, don't give for screening at that time when when the patient is at first trimester scan and there is a fetal pole for you. Just do the scan, see the scan markers, and leave the patient and ask the patient again at 16 weeks. Call the patient at 16 weeks, and once the fetal pole is absorbed and there is no fetal pole, you can go for quadruple screening. Because if there is a part or fetal pole is present, it will release spurious markers and it will interfere with the final result and it will give you a false positive report. Now coming to NIPT or non-invasive prenatal testing, does this change the scene? See, this is how it goes. This is the blood vessel of mother and this is a fetus. So whenever a fetus is there, this blood will be circulated in the maternal blood. So you will have a mix-up. Fetal DNA, this fetus will have the same composition that of the placenta. That's why we do chorionic villus sampling in our first trimester, because the fetal DNA is same as that of the placenta. In between, I'll tell you one more condition is there, placental mosaicism. That is entirely another topic. So for basic understanding, I'll tell you this: the fetus and the placenta will have the same genetic constituents, and this placental cells will be there in the mother. So cell-free DNA is derived from the apoptotic cells derived from the placental trophoblast. These cells will be circulated in the maternal blood, and when you withdraw maternal blood for NIPT, they will sieve this DNA and will find out whether the baby is having an extra DNA. That is the concept of non-invasive prenatal testing. This is how it works. So this is the detection rate of combined test. Detection rate 92 to 95%, with a false positive rate of 3%. NIPT, the detection rate is 99% with a false positive rate of 1%. Then why do you not go for NIPT directly? Then why do you go for combined test? See, basically it is because of the cost. NIPT is costly these days, and we are expecting to a future where routine screening will be given as NIPT with some funding from the government or something. At present, NIPT is costly, and only because of that we are going with the combined screening test in the initial period. So NIPT as a first line test, indications are there. If your mother maternal age is more than 38 or older, you can directly give blood to the NIPT. You don't have to go for combined screening. And if you have an ultrasound finding indicating there is an increased risk of aneuploidy, when you're for any CRL, if the NT measurement is more than 3 millimeter, it is definitely abnormal. So if you have a high NT, you can give the option of NIPT directly to the couple. And if you have a history with prior pregnancy with a trisomy, you don't have to go for directly to this one combined screening. You can give blood directly to NIPT. So these are the first line test indication for NIPT. So can we do NIPT in twins? This is another question everybody will have. Yes, you can do, because it is having the same detection rate as of singleton, that is around 98.2%. But the detection rate of trisomy 13 and 18 will be less. It is not because that it cannot pick up. It is because number of cases with the trisomy 13 and 18 that has been studied is less. So it has a comparable detection rate as that of first trimester, singleton for twins also. Now, coming to screening in IVF pregnancies, what are the things that you have to keep in your mind when you are having an IVF pregnancy? First one is dating. It is not that last periods or something will be there. Dating will be different because it is IVF and you have to see the embryo transfer date, because gestational age is dependent when you are doing screening. So dating has to be correct, properly documented. And if you have an HCG injection, if you have taken HCG injection previously within 1 week, your beta HCG will be more. So that will interfere with your final result and you will have an abnormal result. And also see whether it is a donor cycle, donor age, or maternal age that you have to decide. These are the things that you have to keep in mind when you are having an IVF pregnancy. Now, what all things have to be done when you are interpreting a screening test? I have told you there are three reports will be there, that is high risk, low risk, and intermediate risk. What are these values? So this is a test interpretation. So whenever you have a test, final report, final result, if it is less than 250, less than 250 means, if it is, actually speaking, this is 1 in 250 to like maybe the test is for a final report. You will see after the screening report, you will have a final result. It will be written in your combined screening paper, final risk. So if the risk value is more than 1000, it is considered as a low risk. 1001 to more up, so it is considered as low risk. 250 to 1000 is considered as intermediate risk, and less than 250 is considered as the high risk. Whenever you are having a fetus with high risk, you have to counsel and offer invasive testing. No doubt in that. Whenever you are having a high risk patient, directly offer high risk. High risk means you have to offer this thing, direct testing, that is invasive testing, amniocentesis or CVS. And whenever you are having a fetus with intermediate risk, that is the final value is between 250 and 1000, maybe 750 or 950 or something, you have to counsel them for NIPT, which is a superior screening test. Only if that is abnormal, you have to ask them for invasive testing. And if your final result is more than 1000, it is considered as low risk, and you don't have to do anything. You can advise as proper standard care, which is routine anomaly scan at around 5th month with a genetic sonogram, and see how it goes. This is the test interpretation, and this is how you have to counsel the patient. So now, just to conclude, like, why are we doing screening? It is to prevent. Secondary prevention is our aim. And whom to screen? It is universal screening. And what is the basis? It is the personalized risk to minimize our invasive testing. How to do means, like, we are filtering out the normals and filtering the high risk, so that we can get majority of the easy pickup and early pickup, and for all those things. When to do, I have explained the first trimester, second trimester, and combined. And which is the best one? First trimester model is the best. And where you have to send, it is accredited lab and software. Now, madam has asked me to inform like one more this thing, that is, if your previous child is affected. Previous child is affected is entirely a different topic. Basically, previous child, so many genetic conditions are there. If your previous child is affected and this child workup is done, you have an answer for that syndrome. Yeah, see, I have got so many patients where their previous child will be affected, but none of them, like majority, won't be having an answer. Everybody will say this baby has a genetic syndrome, but it is not worked up. If you're coming with such a question, we are not able to offer you prenatal test. Whenever a baby is affected, first work up the index child, find out the genetic syndrome, and if that baby is having a mutation, please go ahead with the testing of mother and father, so that to find out whether they are the carriers. If father and mother both are carriers, it is because of an autosomal recessive, or it can run in the family, so that we can test the baby or the fetus and find out whether this fetus is affected or a carrier. If your index child is not worked up in the pregnancy period, it is better not to offer anything, because whenever we do some testing, you will have any copy number variant, which is not. Copy number variant means it may be pathological or non-pathological. Pathological means we can say that it is because of any other syndrome. If it is likely pathogenic also, you can explain this can be the cause for some of the syndrome. But there are certain things like VUS, which is called as variant of unknown significance, which is a copy number variation. That means this variation has not proved to cause any syndrome, but this is a variant. We cannot explain whether this will cause syndrome to a baby or not. So whenever, if an index child workup is not complete, initially pre-pregnancy they have to come, get their child worked up, get even the trio sequence, even the parents also has to be worked up. At least the child has to be worked up, and then we get an like mutation or whatever study. then continue with the pregnancy. At around 16 weeks, you can do an amnio and get the mutation done. Or like if they are ready, we can do a CVS also, because CVS is in the first trimester, where I have already explained that we'll take a placental biopsy. It is a bit painful maybe, because we'll have to apply local injection, because we are taking a biopsy. We are taking a part of the placenta with sudden jerky procedure. Amniocentesis is just like withdrawing blood, so the pain will not be much more like when you are inserting a needle to get your blood. That is the same pain you will have when you're doing an amniocentesis. It is tolerable, and they'll be prepared for that. So whatever is comfortable for them, only if the previous child is worked up, we can do the uh, work for in this pregnancy. That's all. And that's all I have. Thank you.
Thank you, ma'am.
Thank you.
Thank you so much, ma'am, for your insightful and enlightening session on aneuploidy screening. Your expertise in fetal medicine and prenatal diagnostics has provided us with a deeper understanding of the importance of early detection, screening techniques, and all. Thank you so much. Delegates can now post your doubts in the chat box, or can use the raise hand feature or unmute your mic to ask your questions directly. Ma'am, there is one question.
Yeah, please.
Ma'am, what is the ideal timing for NIPT, or after combined testing as per risk we have to proceed?
See, NIPT you can do from 10 weeks till delivery. So there is no timing basically. You can start from 10th week of pregnancy till delivery. Whenever you are having a doubt in your combined screening, you can go ahead with your NIPT. What is the next question? Like timing of NIPT, and then what was the next part?
Ma'am, or after combined testing as per risk we have to proceed.
If your combined screening is having a intermediate risk or high risk, you can go with an IPT. That's what. If your combined screening, you will get the report only at around 12 weeks or 13 weeks. Immediately, you can go with NIPT. It is a non-invasive superior screening, so that it is easier for you.
Okay, ma'am. Thank you.
I hope it is clear, whoever has asked question.
Yes, ma'am. Yes, ma'am. Thank you. Ma'am, one more question from my side.
Yeah, please.
Ma'am, as you told that we should do the ultrasound and the testing within 48 hours. So, ma'am, my question was that, like, if we are practicing in some rural area and we don't have the facility at the same center, so can we do them separately, like in some lab we can send it for double marker, and at separate center for ultrasound?
That's
Is
what I'm saying. You can do all such things, but we cannot reliably take those things. You have in rural posting, everybody there will be having FMF accredited platforms. There are certain labs will be there for sure. Okay, so
so
whenever you give the sample after 48 hours, all the hormonal values will be varying at the time when we are doing a scan. So it is always a combined screening, so that we are getting a more detection rate. When you do a scan, and I told you, right, when you are doing a double test, you will get around 65 percentage of this thing detection rate is there. Scan alone have a 70 percentage. Why do we do it together? Is to get our detection rate more, that is to increase it to 92 to 95 percentage. That is the reason we are doing it together. So whenever you are in a rural area, initially only find out the place where you have to get all these things done. You cannot delay. That is important.
okay.
There is no easier way in that. That's why we are doing it and getting a better result. Otherwise, you can do a scan and then ask them for an NIPT from some other place which has a better detection rate. Combined screening means you have to give blood within 48 hours.
Thank you, ma'am. Thank you.
Dr. Bharti Anvekar has raised her hand. So if you have doubt, please unmute and ask directly.
Mm. Yes. My question is physical deformities, all these ruling out is, I totally agree with you, and that's what we are doing. But the mental and the emotional things where the child grows abnormally, and nowadays we find more of crimes increasing.
Mm.
And any research has been carried out regarding this?
I didn't get your question, madam. Like mental ability of the
Men
baby.
Yeah, yeah, yeah.
See, that's what, madam, I have told you. Like, we are not into termination. We are not
Mm.
doing all this thing to find out something and to terminate. I have stated it in the beginning. I think you have missed the beginning part, I guess.
No, no, no. I have listened to that. You are
Yeah,
right. I do agree. You are nowhere you have mentioned about these
yeah,
destructive things. But
yeah.
the only thing is to prevent, because see, in Ayurveda, no, there are a lot of things have been told,
Ah,
and any research is going on regarding that matter.
no,
Because
madam.
see, even when there is a cohabitation between the couple,
Ah,
the thoughts what the couple have, they have the effect on the conceiving the child.
true.
And that way, Ayurveda in our Maharshis have mentioned. So, any research is carried out regarding that. That's what my thing is.
As of now, as much as I know, like there are no such studies, madam. Like we are more into like whatever, like we cannot actually interfere in everyone's, like as you told, like so many things are happening these days. We cannot
Yeah,
interfere in
yeah,
everything. So basically, whenever you are pregnant, like we can prevent all such things by a prenatal invasive testing. If that's what I told. If
yeah,
you
yeah, yeah,
have a previous genetic syndrome in your family, if you have a history of previous baby affected, if you have any genetic syndromes running in the family, if you bring the report, we can definitely find out whether this is affected to the fetus or not.
yeah,
But otherwise, without any, even if like I have been doing scans like since so many years, so whenever we are seeing a structurally normal fetus, I will never assure 100% that this baby is normal, because we cannot say any of
yeah,
the
yeah.
baby's mental status.
Yes,
We have
yes,
seen
very
so
true.
many babies with antenatally they will go very smoothly, but postnatally they will be autistic. But there is no genetic a specific mutation is not there for this autism. There are multiple alleles
Very,
present. So
yes,
I
yes,
cannot
very true,
assure
very true.
baby will be autistic or not. I can just assure them that there is no physical deformities in the baby. And if you have any genetic deformity in your families or anything, you can bring to me so that I can help whether this is
Very,
there
very true, very true, very true.
or like we cannot completely assure them, ma'am.
Yeah, that's what I think was like pre-conception
Yeah,
counseling and some to prevent some research if we work together like Ayurveda and allopathy,
yeah, madam.
something we may come out new things and we can make our next community stronger. Yeah, thank you, doctor.
Thank you, ma'am. There is one another query in the chat box by Dr. Ravindra. Could you please give inputs on caudal factors and prenatal anomaly diagnosis through imaging techniques?
See, that is entirely another topic. Soft markers and ultrasound on like markers is another topic. Basically, this was only aneuploidy screening. I have only made such points today. I think you wanted to know about the ultrasound markers and ultrasound what are the findings that you will see in chromosomally abnormal fetuses. I think that was your question. Is that so, please? Who asked the question, please?
Dr. Ravindra, can you please unmute?
Yeah. He has messaged. Yes. Yeah. Basically, that is, and if you can provide another session, I can explain. Basically, like there are so many syndromic features. Like he wanted to know about the syndromes and what are the findings. That is entirely a different topic. Each syndrome has a different features. Basically, that's how we pick up. Trisomy 21 will have certain features, and trisomy 18 and 13 will be having another features. So that is a different topic, and now that, yeah, I don't think time will be there. Is that okay? Like another session maybe has to be there? Or do you want to know specifically about any syndromes?
So, I think it's okay, ma'am, because this is a CME based on mainly the genetic disorders. I think that will be fine. We will in another session maybe we will plan that.
Okay, madam. Okay.
Thank you, ma'am. Ma'am, next question from Dr. Agali Shilpa.
Okay.
What if the patient got scanned around 17 weeks for the first time in pregnancy? Which investigation would be better to screen for genetic issues with the patient?
Yeah, that's what. If you have missed your first trimester scan screening, you can go for early anomaly scan at around 16, from 16 weeks to 18 weeks. You can see the anatomy well, maybe better than what you see in your first trimester. And you can go for a quadruple screening, which is actually cheaper. If the patient can afford an NIPT, it is always better an early anomaly scan with an NIPT screening.
Thank you, ma'am. Hope it is clear. Next question from Dr. Hridya Ramesh. Ma'am, are there any known criteria or reasons for trisomy 21 babies undergoing spontaneous abortions in first trimester as opposed to those that survive, given that the risk decreases with increase in gestational age?
Yeah, trisomy 21. Yeah, this previous question can also be answered together, I guess. See, trisomy 21, I have already explained there are so many cases with the congenital heart disease and also like associated AVSD, atrioventricular septal defects, and all such cardiac anomalies will be there for trisomy 21 babies. So whenever these babies are there, they cannot survive as compared to the normal fetuses. And also hormones will be so high, hormonal values will be so high that it is very difficult for them to survive better than a non affected fetus. So usually trisomy 21 babies, some of them will abort spontaneously because they are having like variation than normal. So it is difficult for them to survive and they will abort by themselves. Those who can survive will not be having any structural anomalies. That's the reason we are not able to pick many of the trisomy 21 fetuses, which is continuing, and we are getting trisomy 21 fetuses. Those who have structural anomalies will, majority will get spontaneously aborted or will have an IUD. See, whenever this trisomy 21 pregnancies are continuing also, they will have fetal growth restriction after 28 weeks basically. Yeah, this trisomy 21 will have so many features like I have already told ABST. Then some of them will have like what is that? Omphalocele. All such things will be there. So some of the structural anomalies we will correct. Some of the babies will have congenital diaphragmatic hernia. All such congenital anomalies will be picked up only later if it is surviving. Some of them will be having major congenital anomalies and so they will get aborted. I hope it's clear.
Thank you, ma'am. One more question, ma'am, from Dr. Reena Kulkarni. What are and to which extent antenatally detected anomalies can be managed in fetal medicine?
See, there are so many anomalies basically which we can, fetal therapy is there. Fetal therapy is only to treat fetus. There are, I don't know, like who, this is from Bangalore, right? Yeah, there may be fetal medicine institutions there. Fetal therapy is another unit only where you can treat the babies when you have a twin babies, like monochorionic twins are there, and one of the baby is having fetal growth restriction or TTTS. I don't know whether you people are aware of TTTS syndromes, because when you are having a common placenta will have sharing and there will be anastomosis. So one baby will be affected and the other baby can be normal. So we used to do laser therapies so that the connection between the placentas will be cut so that it can be divided into two separate placentas, and we will consider it as a dichorionic placenta, and the pregnancy can be continued without complications. This is one. Then you have fetal anemia, where we used to give intrauterine transfusion. When fetal anemia means like whenever you are Rh negative and your husband is Rh positive, you have a previously Rh positive baby, and this pregnancy you are ICT positive with a dilution more than like ICT positive with the titer more, and your baby is having fetal anemia, we used to give intrauterine transfusion. Then what else? Then if you are having a polyhydramnios, very high like around the sac, we used to give amnio drainage so that we will reduce the fluid around the sac and give maternal, like we can reduce the maternal discomfort. Then I don't know whether you are aware of like posterior urethral valve will be there in some boy babies. Posterior urethral valve will be very thick and it will not let the urine out, so that the bladder will be in the keyhole shape. So we use laser to correct or to coagulate that posterior bladder, posterior urethral valve, and urine can flow. So many procedures are there, therapeutic procedures, so that we can help the babies. And then multiple pregnancies will be there, maybe around quadruplets, like sextuplets, so many will be there. When you are in an IVF center, and they will actually implant 3 or 4 embryos so that their success rate will be more. So when you have a triplets and higher order pregnancies, they will come to us for reduction basically. So we used to do fetal reduction procedure so that the pregnancy can be continued till 36 weeks and they will get at least 2 babies healthy. So these are the fetal therapy parts that we do. And one more thing is that whenever you are having a twins and one baby in monochorionic twins, if they are, I have already told you that they are having an anastomosis and connections will be there. So if one baby's fetal heart rate, if you have a bradycardia or some other anomalies, if you are previously enrolled, if you have 2 babies and one baby is affected, the other baby is normal, it is a norm that we are supposed to take both babies. Like we cannot do anything. Like one baby will be normal, the other one will be having a significantly huge abdominal baby with so many multiple malformations. So we will have to live with that baby. So now that you have like RFA, radio frequency ablation technique, so that you can actually reduce the affected baby or with the anomalous baby, and you can continue on the singleton pregnancy. Like with a healthy baby only you will have. I hope. Thank you.
Thank you, ma'am. Ma'am, one more question from Dr. Kirti Vijaykumar.
Yeah.
What key factors influence the accuracy of CRL measurements in the first trimester and BPD measurements in the second trimester for gestation age estimation?
Yeah, exactly. See, CRL has to be done clearly. It is like, see, for example, a 40-year-old lady can be 70 kg and also 60 kg or 30 kg. We don't have criteria. That's 40 years means you are supposed to be this. Similarly, CRL and NT are dependent to each other. Whenever your CRL is more, CRL has a measurement. Like CRL has actually, like when we are trained, when we have FMF certificate, they will give you what all points to be there noted when you are taking a proper CRL. It has a guideline to take a CRL. When you take a proper CRL and for that a proper NT, only then you can tell that this baby is abnormal. If your CRL is like crumped out and you have a very if your baby is not even lying down, baby is standing, and then you take a crown to rump length and measure, it is not going to be accurate. That will reflect the final risk, and you will simply label that as high risk or anything. I have we used to get scan reports where CRL will be like very less, maybe around 45, and the NT will be around 2.8 or something. So when you calculate that, the risk will be very high. It is not like that. Whenever you are having a big CRL means crown to rump length. It is the from head to toe length. It is actually the sacral region. So from it is that length. For that length, corresponding has to be the NT measurement. If you are following all the criteria and guidelines, your risk and the detection rate will be more accurate. That is the reason. BPD you don't have to worry about. Like it is actually a rough measurement, BPD. But together with that, like when you are taking a measurement, when you are giving the blood, you should know that this baby fits into this criteria where the BPD measurement is between 31 to 52. If you are not giving that, all this scales, everything has certain standardization where the hormonal levels are supposed to be in that level. For example, in second trimester, only if your BPD is between 31 to 52, hormones can be assessed for aneuploidy. Or the measurement for BPD is very simple. It doesn't have much technique and all. You can just keep the scan probe over the head of the baby, and any person can take the BPD. But you have to make sure measurement falls in the correct criteria. That's all it is. But first trimester is really, really difficult. Even if a trained person will struggle to get the baby in a good position to get a good CRL and NT. Thank you.
Thank you, ma'am. I hope the queries are over. To all attendees, thank you for joining this enriching session and for your active participation in the Q&A session. We hope you found it as informative and thought-provoking as we did. We look forward to seeing you in the next CME session. Thank you so much, Akhila ma'am, for joining with us.
Thank you, everyone. Thank you. Thank you so much.
Next session will be part 2 of genetic testing by Dr. Vinita AO at 6 p.m. tomorrow. Thank you. Thank you all.
Thank you. Can I? Madam.
Can we open the session for discussions?
No, it's over, ma'am. I think she was. Thank you, Akhila ma'am, for the Q&A and all. Thank you very much, ma'am.
Can I leave now?
Yeah, sure. Thank you, ma'am. Thank you very much.
Thank you.
Thank you, ma'am.